Good morning, everyone, and thank you, Dr. Baines, for your introduction. Today, we're honored to present a report developed in partnership with the International Center for Humanitarian Affairs. Our report presents an in-depth assessment of the multidimensional barriers that refugee women and girls face when it comes to accessing their maternal and reproductive health care in the Kalobey Integrated Settlement in Kenya. Our report focuses not only on what prevents the Kenya Red Cross Society from providing care, but why care remains so hard to reach and to deliver. Through our assessment, we discovered two main interlinked barriers. First, the barriers to service provision, which are the systemic gaps in infrastructure, staffing, funding, and logistics that prevent healthcare workers from providing care. And second are the barriers to service utilization, which are the structural, social-cultural, economic, and legal challenges that refugee women and girls face that prevent them from accessing the services that are available. Our assessment was done through a mixed method approach where we conducted a comprehensive review of literature and policies, and most importantly, voices from the field. We carried out several focus group discussions and interviews with key informants such as NGO workers, healthcare workers, humanitarian staff, county officials, and refugee women and girls through volunteers. Their voices shaped our understanding and our obligation to act. But before we get to the present, we must understand the past. Kenya's refugee policies have evolved through a series of sharp turns. The 1970s and the 1980s were what some referred to as the golden age of asylum, where refugees, mostly from Uganda, could work, move freely, and settle locally. However, by the 1990s, everything changed. In 1992, Kenya saw a surge in its refugee population from 15,000 refugees to over 400,000 refugees due to conflicts in neighboring countries. Facing security concerns and pressures, the Kenyan government shifted towards a policy of encampment. The Kakuma refugee camp was born out of this policy in 1992. And by 2016, the Kalobey Integrated Settlement was established to ease Kakuma's overcrowding and to promote socioeconomic integration. And yet, despite these attempts at inclusion, refugees remain tethered to restrictive policies and facing inequalities. For over 30 years, this encampment policy has dictated nearly every aspect of refugee lives, from where they can move to where they can work to their health and their education. It was only in 2018 that refugees were able to enroll in the National Health Insurance Fund under a pilot program funded by the UNHCR. And it was only recently with the Refugee Act of 2021 that refugees were granted the right to work and to move, but only within designated areas. Today, with the Social Health Authority and the Shirika Plan, the Kenyan government aims to grant even more access to refugees, including their health and education. These are promising steps, but they remain incomplete. Kalobey Integrated Settlement is home to tens of thousands of refugees living in harsh and arid conditions where temperatures routinely exceed 40 degrees Celsius. The land is dry, rocky, and largely non-arable. This means that agricultural self-sufficiency is not always an option, and refugees have to rely almost entirely on humanitarian assistance. And because of this, healthcare provision is severely restricted.
Let me now walk you through the maternity and newborn unit at the Natukobenyo Health Center. When we arrived, we saw a group of women waiting under the tin roof in the still hot air with their babies tied to their backs in kangas. They carried with them a small bag with some essentials like food, water, or a small tumbler. And this is the first reality of maternal and reproductive health care in Kalobey. Care does not begin with consultation, but with endurance. The situation inside the facility is no better. There are only 10 nurses in total, 2 or 3 works a day shift, and 1 or 2 remains at night. And they do everything. They deliver the babies, they clean the beds, fill out the paperwork, translate, and even donate blood when the need arises. So they are midwives, nurses, ambulance dispatchers, and crisis managers, often all at once. Moreover, there are no specialists in Kalobey. And because of this, many of the staff are burned out, both physically and emotionally. Some of them have had to work 4 days straight without any days off. And there is no trauma counseling, no support system. And in this climate of exhaustion, respect and empathy sometimes fades, and communication breaks down, and this affects quality of care. With limited resources, the Kenya Red Cross Society is doing their best to ensure quality care, but they can only do so much. There are only a handful of beds in the unit and just 3 in the delivery ward. And when a pregnant woman is in distress, with just 3 ambulances serving a population of approximately 77,000, it's often a race against time. And when we visited the facility, only 2 of them were functioning. And these ambulances, they don't have any life-saving equipments, they're just transport cars. And the roads within the settlement, often unpaved and flooded during rainy season. So even if an ambulance is available, it can't always get through. And it is especially difficult for women from Village 3 in Kalobey who lives quite far from the facility. And if a woman is in need of C-section, then the nearest operating theater is 30 kilometers away, and the nearest ICU approximately 150 kilometers away. So they need to be referred to these facilities, and this adds to delays, and insurance coverage comes to the picture. So in situations like this, survival becomes a negotiation, and the woman is forced to choose between delivering at home or walking to the clinic or feeding their child or taking care of her familial responsibilities.
And the crisis runs deeper as we zoom into the refugee communities. For some refugee women and girls, decisions are made in desperation because options simply do not exist. Access to abortion services remain illegal in Kenya, where exemptions for the procedure are allowed only if the mother's life or health are at risk. In Kalobey, this restriction pushes many women and girls towards unsafe abortion methods. Healthcare workers described how many women and girls often begin terminating pregnancies at home using traditional herbs, anti-malarial drugs, or painkillers, and arrive at the facilities only once their health begins to deteriorate. Many women go through unintended pregnancies due to sexual violence, rape, or survival sex. Others are too impoverished to care for another child. It's not just the physical barriers, though. There are structural ones, too. Without a refugee ID, women and girls can't access free care. If they are undocumented, they're not covered by the National Health Insurance Scheme. And they can't just leave Kalobey. Kenya's encampment policy restricts refugee movement, and patients are required to obtain a travel pass, even for referrals in other towns. Even if they need surgery, even if their baby's life depends on it. One mother, diagnosed with cervical cancer, was referred to a facility in Eldoret, which is an 8-hour drive away from Kalobey, for treatment. But because she didn't have proper documentation, she was sent back to the camp, where she deteriorated slowly. Chronic poverty and restrictive encampment policies further limit livelihood options. Turkana's arid climate prevents subsistence farming, leaving refugees reliant on shrinking aid. This worsens nutrition outcomes among mothers and infants. Cultural barriers just complicate things further. Kalobey hosts refugees from over 25 different countries, from as far as Afghanistan and even Ukraine, creating significant knowledge and language barriers in healthcare provision. Moreover, poor mental health outcomes are widespread, compounded by alcohol and drug use in the settlement. Some women still prefer to give birth squatting, a traditional birthing practice that allows gravity to support labor. But many health facilities do not accommodate this. So these mothers give birth at home, relying on traditional birth attendants. Moreover, decisions about maternal and reproductive health care are often not made by the women themselves, but by their husbands or male relatives. In some cases, they're compelled to remove contraceptive implants, and in other cases, they refuse permission to seek care, even in medical emergencies. There have been instances where consent for life-saving procedures had to be obtained from husbands living in other countries. And in healthcare, delayed decisions can cost lives. In more worrying news, US aid has withdrawn its funding. Over 5,000 humanitarian programs terminated globally. And they're not the only one. Donor fatigue is rampant when it comes to Kenya, and many traditional donors are shifting their focus to other areas of conflict. Calo Bay has already felt the impact. With reduced humanitarian budgets from traditional donors such as Germany, the US, UK, and France, and other humanitarian agencies, assistance has begun to disappear. Food vouchers and nutritional programs for mothers and infants have been put on hold, resulting in recent protests from the refugee communities. Staff funded by USAID and the Bureau for Population, Refugees, and Migration have been laid off. The supply chains for HIV treatment, malaria medication, and essential maternal drugs are breaking down. Healthcare workers report rising cases of anemia, miscarriages, and low birth weight among infants. So what's the way out? What do women want? They want to be treated with kindness, to be called by their names, to be offered clean facilities where they do not have to share beds, to be able to deliver in dignity, not shame, to have pain relief, a midwife by their side, and a facility that understands not just their bodies, but also their stories. One NGO worker said it best. We go to the refugees because we believe in their power to determine their futures. And we believe this must be the norm in all humanitarian settings. Maternal health is not just about funding or infrastructure. It's about rights and respect. It's about recognizing that even in displacement, women have the right to live and give life with dignity.
With all this in mind, we would now like to present a series of policy recommendations mapped over 5 to 10 years that aim to improve maternal and reproductive healthcare in the Calo Bay Integrated Settlement. These recommendations are not abstract ideas. They are grounded in the real, daily challenges faced by women and girls navigating motherhood and survival in a fragile humanitarian setting. Without adequate funding, infrastructure, and national-level policy shifts, these communities will continue to fall through the cracks. First, we recommend consultation with the refugees themselves, and not just as beneficiaries, but as decision makers. Enhancing healthcare services for refugee women and girls requires acknowledging their diverse cultural backgrounds and actively incorporating their voices into the planning and delivery of care. Through participatory surveys and regular dialogue forums, we can ensure that services reflect their current realities and cultural contexts. With community trust comes better uptake, stronger outcomes, and long-term behavioral change. Second, we recommend expanding the human resource pool. Calo Bay needs more healthcare workers, especially those better trained in culturally sensitive and adolescent-friendly care. We also recommend training refugee women as community birth attendants, as this will not only empower local leaders, but it will also provide safer alternatives for women who need to give birth at home due to cultural or logistical barriers. Third, we recommend enhancing access to healthcare. For many expectant mothers, the distance to a clinic can be deadly. That's why improving access to transportation is urgent. Our report includes practical interventions for this matter that can save lives, such as those listed on the screen. Fourth, we recommend ensuring the adequate availability of medical supplies. Investment in consistent medical supplies, cold storage for vaccines, and a dedicated blood bank are necessary to ensure that preventable deaths, such as postpartum hemorrhage, are no longer the norm. And fifth, we recommend improving healthcare facilities and infrastructure. Expanding and consistently upgrading healthcare infrastructure, including maternal and neonatal units, is necessary to ensure the comprehensive and life-saving care is delivered. These spaces must reflect the privacy, dignity, and care that every mother deserves. These recommendations are more than policy. They're a call to action for partnership, funding, and national commitment, a call to reimagine what care looks like in humanitarian settings, not as a charity, but as a right. Let's invest in mothers, listen to communities, and build systems that don't just save lives, but affirm them. Before we finish, we also wanted to acknowledge Brian Nikala, Natasha Lulia, and Dennis Wary at the International Center for Humanitarian Affairs and the Kenyan Red Cross Society and UBC for their help, guidance, and support. Thank you.
Thank you. Thank you, Team Aicha. That was amazing.
Thank you.
We'd love to invite Brian, I think, into the space. Brian and Dennis? Here we go. Hi, Brian. Hi, Brian. This is Brian Ikala. Brian, I'm Erin Baines. I'm the faculty lead for this amazing team. I realized that you've just had an opportunity to work with them the last 8 months and hear the presentation and the results of their labors. So we'd invite you to make the first kind of comment or feedback, and if you could ask them any questions that you have regarding their work.
Okay, thank you so much. My name is Dr. Brian Ikala. I work for the Kenya Red Cross under the International Center for Maternal Affairs, which is an affiliate of the Kenya Red Cross Society. Our work is in innovation, research, data, among others. So yes, we've been working with this great team for the past 8 months. I would say that it's a team that is dedicated. It's a team that like they push themselves to the limit, and I think they're open to trying and exploring new areas and new stuff. And I think how you reach this topic is you already have an ongoing project that touches on resilience building of the refugee population, and the area of maternal healthcare was an area that was kind of lacking a bit of attention. I think the fact that yes, there is support being provided from government and other non-governmental stakeholders, but now that particular bit, there's bits of improvement in terms of access, in terms of the policy environment, even in terms of joint programming. So we just thought perhaps this can be an opportunity for us to think through as a team and then just do something, either a research paper, an assessment, just something that will maybe kickstart the conversation, and something that maybe you can even pitch to different stakeholders, not only for support, but for purposeful commitment. We have been in contact with regards to the work, and I think we gave our comments prior to the presentation. Most of it was around methodology. Yeah, most of it was around methodology, and also terminologies or language that is quote unquote government friendly language, because Red Cross is established under an act of parliament within the constitution, and so our primary mandate is to let me say complement the efforts of the government. Yeah, so it was more on basically more on that. Maybe allow me to maybe invite Natasha or Dennis if there's any other thing maybe I might have forgotten.
Thanks, Brian. Natasha and Dennis, do you have any questions for the team?
Natasha, do you want me to go first?
Yes, please.
All right, thank you. All right. Thank you so much, Dr. Brian. My name is Dennis Were. A public health officer working with Kenya Red Cross based in the refugee operations. And this is to appreciate the team and to also confirm that we've worked with them, of course, been part of the process throughout, and it's just to also appreciate their dedication and their good work, and also to confirm that I've been part of the process to help them contextualize. Dr. Brian mentioned the aspect of ensuring that we have a product that is more aligned to the government language, but I'm also confirming that I was part of the process to ensure that we were able to have a product that is able to speak to the real challenges, the real needs that we are experiencing while working with this refugee population. So majorly around working with these women every day and the challenges they go through, and as the private sector, the players in this space, what we deal with every day is what we really try to ensure that we have we have a document that is able to really inform the world how the picture looks like as a partner or a stakeholder or a government to host refugees in the country. I do not have really a question to the team because we've been able to walk through them the journey and even be able to help them understand the culture of this context, how the population looks like, building the history, and they got it right. So thank you so much, and we hope to make use of this product moving on. Thank you so much, Ove, and I would want to hand over this to Natasha. Thank you.
Thanks, Dennis. Natasha, any questions?
Hi, no, I don't really have any questions. So sorry, I'm just recovering from a flu. I'd just like to give forgot to introduce myself. My name is Natasha Lulia from the Policy and Advocacy Unit at ICHA. And I'd like to commend the girls for the good work they've done. Special shout out goes to Netheena and Najma. They're very well aware of the journey we had to take so that we get to the camp. I was really impressed by their tenacity and their willingness to go so far out of what would be considered the norm when you visit certain countries. With regards to the paper and the report, I think it was well written. It was a collaborative process where we both worked together and they were very responsive. They took our corrections to the best of their ability, and I saw it reflected in the draft, and I cannot wait to see the final report that they come out with.
Thank you so much, Natasha.
Thank you.
That really means a lot.
I don't know if you can see Natasha, but you've moved the team with those words, because it is true that as we started the presentation here today, it is very difficult work, and it does take a great deal of like courage and tenacity and to do this, and it takes a special team to make it happen to realize it. Well, our next question is the faculty lead, which is me. And I will ask you a question, and it's something we've talked about all along, which is this devastating impact that USAID's decision to, or not USAID's decision, but rather the president's decision to cut back USAID, the impact that's had on refugee populations. And in addition to that, we've seen a real rollback of aid in Europe in order to redirect it and invest it in military. So how has that, impacted your plan or your recommendations? And how will your recommendations for action be realized given this kind of enormous stress that they're now under?
So one of the things we hope comes out of this report and our recommendations is that the team at Kenya Red Cross Society and International Center for Humanitarian Affairs can utilize the report for advocacy and lobbying efforts to demonstrate to donors and maybe other relations such as public-private partnerships what is needed, why it is needed, and how urgent the matter is. And another big thing coming up in Kenya is the Shirika Plan, which also helps to alleviate and find other means of funds that aren't just purely donor-based.
So actually, USAID, while it was a major donor to refugee operations, it is also coming along with donor fatigue from other humanitarian agencies and donor countries. Just to give you some sort of a picture of what global humanitarian assistance levels are like, the UN OCHA has said that there's only about 48.4% of the required funds for humanitarian programs in 2024 globally were obtained. So humanitarian funding is declining all over, and In Kenya's context, I feel that the Shirika plan is a futuristic plan if implemented properly, because it can help integrate delivery of healthcare provision within the national health system framework, as well as what is being currently operated by organizations like the Kenya Red Cross. This will help bring in more funds that can be utilized to ramp up existing facilities or maybe hire required staff. So we do recognize that US aid and donor funding is required, but I think Kenya is already thinking about future plans and trying to bring up a plan of self-reliance.
Excellent. Excellent reflection on what it was a difficult question. We have some time, and I'm sure that you'd love to hear some questions from your colleagues or the audience in general. I see one with Nishi.
Wait, Nishi. Thank you for your presentation. I was just wondering, like, there must have been a lot of consideration. There are a lot of issues in refugee camp. And why did you specifically went for mothers and reproductive and child health?
Actually love this question because we had a hard time narrowing down on the scope of our project. We know we wanted to work with children at the beginning, and then we wanted to work with children and mothers. And after talking with Brian, Natasha, and Dennis, they helped us guide through our process selection. And we finally decided to focus on mothers and their reproductive and maternal rights, because if we can improve those reproductive and maternal rights, they can carry out a good pregnancy, a healthy pregnancy, deliver a healthy baby, and that improves that child's quality of life from the very beginning. So we would have a cascading effect throughout the camp. And that's why we decided to focus solely on mothers.
Thank you. Thank you. We have another question. Yes, please, right at the back.
Okay, hi. Hey guys, nice presentation, even though I came at the end. So it's pretty interesting to me that, you're speaking about an issue in Africa that is really prevalent. And from Nigeria, we have refugees too as well. I would like to ask, we have a serious issue in Africa where a lot of NGOs operate in Africa, there are a lot of donor funds, but there is very minimal impact seen over the years with the beneficiaries or the people who are actually really impacted by a lot of the crises that have happened. What solutions do you have to improve those funds actually going to impact the beneficiaries rather than just having a lot of names, going around, a lot of stories about huge sums of money moving around the continent, but no direct impact improving the lives of those who are impacted by crisis? Thank you.
Thanks, Erin.
Maybe I can start and someone else can join in. So, I mean, I do understand that there are issues with how humanitarian operations have been conducted so far. But I think when we visited there, we also saw the endurance and the resilience of those operations. And we were able to understand how it really impacts lives on the ground. And in terms of how, how operations can be improved, like I mentioned, with the Shirika plan, there is going to be integration of delivery of healthcare and education services within the national delivery systems, as well as with implementing partners. So we foresee this improving impact as well. And that is one way I think that this issue can be addressed.
To add on to that, we did think about this a lot, and that's why one of our recommendations is to also have a more bottom-up approach, to involve the refugees, to hear from them directly what they need, to allow them to have direct communication links with these donors, with these public-private partnerships, so that they can know from them what is it that they need, not be told what they need, but actually hear what is it that they need.
Thank you. That's another great question and set of answers. We've run out of time. It went by fast. Is there any final word from one of the team in Kenya, from Aicha?
Yeah, I think I think I'll also weigh in on the last question. In terms of impact being felt on the ground as a result of external support. I think one of the first and foremost things, maybe from implementing organizations, is to define how success looks like. Once that is defined, then when these other external support bodies or donors then invest in your system or in your programming, then you're better off to direct them exactly where the success will be felt. So let the success not be defined by external parties or bodies, but be defined by the organization itself. And then secondly, on the same point, there's a lot of discussions around localization, and it is something that is slowly picking up momentum as a way of strengthening the so-called impact on the ground. And it can take several approaches. It might mean an external donor body working directly with the county government or particular implementing body on the ground or particular community-based organization or even the government. It might mean as well local actors coming into consortiums together to address particular issues, and it might mean as well things around public and private partnerships as just a way of like helping in humanitarian support and alleviating human suffering. I think I'd like to compliment the university for this great initiative under the Global Policy Project. And I think this is the right platform for us to start conversations around. Then how do we define either the aid model or the humanitarian assistance model based on things like research moving forward? It's not really about government to government interest, but it's about evidence-based informed decision making and conversations. And I think this is where it all starts. Once we integrate some of these quote unquote professional things that guys do within the education system, then we'll have a caliber of individuals who already prepared on how they look at development because they have interacted with the development right from school. And then it will be easier for them to transition and contribute uniquely and in whichever context. And I think on the larger scale of things, it also strengthens localization. That means global concepts within local mechanisms. So also, yeah. So I think let me not talk too much.
Yeah, I think it's an issue we could all spend the whole day trying to talk about, but we're so grateful to you. A big round of applause to the team and their support and to the fantastic presentation. Thank you. Bye.
Thank you.
So we'll now call